Back tonight on In Focus, there appears to be a mismatch in the number of doctor positions in clinics versus those in hospitals, and the implications for rural health have been almost dire when the country is facing a pronounced shortage of doctors, leading to great challenges in outlying areas. And it only gets worse to note that the state does not have a budget to fill vacancies in hospitals. Joining us now for some insight into the dichotomy is Russell Rensburg, Director at the Rural Health Advocacy Project. Russell, good evening and thank you very much for your time. Should South Africans accept this answer from government that says, well, we have a mismatch because provincial health department budgets have increased at a slower rate than the intake of medical students? Is that enough?
We'll never have enough doctors or enough money to meet all the healthcare needs. And I think what we need is probably better utilization of the resources that we do have, and make sure that any public money that's spent towards funding publicly funded healthcare services should really be organized and deployed in a manner that prioritizes the needs of the 80% of the people who can't afford to access the private healthcare sector. So I think we need some more innovative ways of dealing with it. In some ways, I would say we are a victim of our own success in terms of the training of medical officers, which we've increased dramatically over the last 10 years. And currently, we add about 1,800 new doctors to the system every year. Those 1,800 doctors spend 3 years in funded positions in the public service, 2 years as interns, and then another year as community service. But unfortunately, most of the new capacity is deployed into a very expensive hospital system. Our interns are only trained at large hospitals because that's where the capacity is to provide them with the mentorship and support that they need to complete their internship. And then when it comes to community service, rural hospitals don't really benefit much in terms of new posts flowing into rural areas. So while we've had growth on the one side, we really have a decline on the other side. And just overall, our population of healthcare workers in the public sector is becoming quite old. Yeah. So there's a lot of underemployed doctors and nurses in the system.
Yeah. So you're saying the fact that we simply just don't have enough money to fill vacant positions or to create additional ones could be true, but there is something that we could do about it. We can better use the money that is there to be able to bring in more doctors and create more positions. How?
Well, I think it's a balance of better deployment. It's really looking at how we respond to healthcare needs. We can have the first come, first served basis where people just rock up at central hospitals and we treat them. And obviously we'll always be overrun. We'll never have enough. Or we can apply more intelligent solutions and start letting the data drive our decisions. So one of the goals that South Africa has, and also globally, is that we signed up to introducing universal health coverage or providing universal health coverage by 2030. Right? Now, to do that, we need to break that up. What does universal health coverage mean and who does it affect? So we already have some very good studies in South Africa suggesting how we break that up. So there's generally about 3 different disease categories. So the first is high users of public services like for reproductive and maternal child health services. So those are services like antenatal care that pregnant women get during their pregnancy. There's reproductive health services that are available at our clinics and some community pharmacies, as well as other family planning services that are available through the public sector. So we've developed an index and tried to the Health System Trust have developed an index to see how are we doing in terms of progressing on those particular indicators. So in the case of maternal and child health, we're doing quite well. We've increased, maternal mortality has for some time trended down. Now during the pandemic it went up. But how those outcomes are distributed in our country sort of follows the story in South Africa, where in urban areas the quality of life and the access to services is so much better than what it is in the 41 or so rural districts that make up rural populations in South Africa. That's more than close to 70% of all districts, given that we only have 52. 41 of them are considered rural. Yeah. And the people living in those areas have a lower quality of life, have higher levels of unemployment, have greater reliance on public services, and then paradoxically also are the worst utilizers of public health services. So I think in terms of investing smart and using the data to drive our decision making, we can invest the capacity that we do have into those areas with the least health coverage. And by doing that, we can actually increase the overall health status of the population. But yeah, we can't continue going on in the way that we do at the moment. It's just not sustainable. We can't afford it. And we'll see more collapses like we've seen at some of the hospitals reported in the media recently.
Was the moratorium on filling of posts the best intervention at that time? Was just the lack of creativity? And what was the unintended consequence of that?
Look, I think the unintended consequence is that, there's a global shortage of healthcare workers. There's about 18 million that are needed globally to meet health worker need. Health worker populations are very mobile. So when you start placing moratoriums on posts and the like, you have the potential to have a lot of healthcare workers leave South Africa, right, and no longer be available for public service. On the flip side again, when we have weak economic conditions, that's why your previous segment was very encouraging that growth is beginning to recover to pre-pandemic levels, at least over the last 2 quarters, is that public sector employment is reliant on the revenue that they can raise. So if the economy is weak, and it has been for the last 6 to 7 years, the amount of money that gets distributed to provinces really in real terms start decreasing. And their ability to employ or expand provision is really dependent on the money that they can get. And at the moment, it looks like things are going to get worse before they can get better. And in that kind of environment, we can't sort of sit on our hands and try and imagine how much more money we do. We have to start looking at how can we work better than with what we got. How can we improve health outcomes by using information correctly? How can we improve accountability for the funding spent by tracking the performance and the health outcomes? And really just beginning to start changing the culture of public service so that the investments that we make ultimately do lead to better outcomes. In reality, South Africa has been increasing health worker salaries with the introduction of things like the occupation-specific dispensation in 2010. And while we increased the average wage in the public sector for healthcare workers, the result was that as economic conditions got weaker from 2012, that growth in remuneration made it super difficult to bring new healthcare workers into the system. That's why we're sitting in this weird position now where we're producing let's say 1,800 new doctors every year, but we're probably only absorbing 180 of them into the public service. So we need some fresh ideas and fresh perspectives to reorientate our health system.
So some temporary suggestions are a different contracting system needed. An evaluation found that the lack of adequate planning impacted the coordination between GPs and National Health Department, as contracted GPs were essentially viewed as subcontractors. How is that going to help us?
Look, again, I think, let's say again, there's about 3,000 clinics. Right? In the pilot studies, what we did is, what the country did, we ended up paying GPs for every patient that they saw. Right? So we know and that really games the system. So the type of claims that came in through the GPs that we contracted into our clinics were actually way beyond what we could afford. So on average, we were seeing maybe 60 patients, but they were contracted to see 30. So that's double the budget that would have been spent. And because they weren't employed by the health service, it was difficult to supervise them and integrate them into the health service. So if we come with a different GP contracting model, where we can say, let's contract an additional 7,000 doctors into primary healthcare with 2 clinics so they can alternate, and we employ them on a fixed-term basis rather than through sessional work, we can probably get better bang for our money. But that's why we do pilots, and I think we learned a lot through that, and we definitely have better information now on how to deploy general practitioners and other teams into primary healthcare centers so we can reduce the cost per patient. Because at the moment, in 8 out of the 9 provinces, the bulk of healthcare services are accessed at hospitals rather than clinics. In fact, utilization of our clinics has actually gone down. So what I'm saying is that what the whole system needs to do is we need to look at the data. We need to understand what are the trends that we'd like to change, and then start working together collaboratively with the professionals, with the universities, with the the bureaucrats and try and figure out how do we build and restore this health system so that it's responsive to the needs of the majority of the population, and that we can start tackling some of our big health emergencies, most notably TB, where close to the same amount of people that died officially from COVID died from TB. Every year, 61,000 people die from a curable disease. And we should be doing a lot better. And really what I think now is we can't afford the system that we have at the moment. The whole system is beginning to fall apart. And I think we need to sort of go back to basics and start strengthening primary health care, including up to district hospitals, ensure that we improve the health of our population. And then as a second part, start looking at how we can better manage our hospitals so we can get more return on investment. But the way it is at the moment, the system will not be able to sustain itself without any significant reform.
So one of the other reforms suggested is particularly around the higher education space to boost the admission of students from rural areas. Would that make a massive change to the rural problem?
Okay, in some instances, yes. It depends which reports you read. There are some successful foundations, like I think the Ntombo Foundation, that's quoted in the article, have fantastic retention results with students that they recruit in the rural areas or return to rural areas. We also know that the Walter Sisulu University also does very well at getting training students in rural settings, and they end up staying there for longer. But at the moment, the limitation is not where the student is coming from. The limitation is coming from the funding that is available to absorb those doctors. They may go to do their community service in the rural hospital, may want to stay for an additional year. But if there's no post and there's no money or there's no opportunity to contract them in, they're likely to leave. So it's really how can I put it, a demand side problem now rather than a supply side, because that we've amped up with the Cuban program, with the universities increasing the amount of students. But the rural retention at the moment, one of the main factors is financial. If the budgets were available and the budgets were sufficiently decentralized at the district level, we could actually create some posts for those doctors who would like to stay there. But my main argument is, though, that we should think more about how we deploy those doctors. Just having them sit at rural district hospitals doesn't really help solve the problem, even though it mitigates or mediates some of the challenges that doctors face in those hospitals. But we do need much stronger primary health care. And I think in the short term, that means having more doctors available at primary health care clinics where it's significantly cheaper to treat many of the ailments and diseases that make up the UHC index.
Russell, I appreciate your time. Thanks for coming on. That